I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome to Journal Club. Top Med Talk.
I'm going to be looking at two papers today, both from the British Journal of Anaesthesia. They're available online. I'll put the links into both of those papers in the show notes so you can get access to them. And they're both about oxygen. One about the effectiveness of 80% versus 30 to 35% oxygen during major surgery, and the other one about the safety of it. So I'm going to pick those off in two parts. I've got two guests with me, regulars on Top Med Talk. I've got Tim Miller, who is the Chief of General Vascular and Transplant Surgery at Duke, and is also the President-elect, just about to take up his office of the American Society of Enhanced Recovery. Tim, welcome back to Top Med Talk.
Thank you, Monty.
How are you today?
Very well, thanks.
Excellent. So in your role, we're going to be discussing papers here that deal with quite a broad sweep of papers, but I'm guessing with your title, General Vascular Transplant, you on a regular basis look after, or on your watch, patients are looked after that fall into these categories.
Yeah, a lot of patients undergoing all types of major abdominal surgery, vascular surgery.
And a large North American well-known institution. So I just want to put that in context when we come back to how clinical practice matches onto these various different recommendations and guidelines about oxygen. Our other special guest is another regular on Top Med Talk, Professor Mike Grocott, who's a Professor of Anaesthesia and Critical Care at the University of Southampton. He wears a number of other hats, including being on the Council of the Royal College of Anaesthetists. But for these discussions, I want to highlight that you're Editor-in-Chief of Perioperative Medicine, along with some other colleagues. And you're also the chair of the Extreme Everest Oxygen Research Consortium. So Mike, we're going to be discussing oxygen in some detail. What's that consortium all about?
So the Extreme Everest Oxygen Research Consortium, which, as you know, having been a long-standing partner in this endeavour, we've been doing essentially basic science lab rat studies, but our lab rats are humans that we take to altitude. And so we've got a great interest in some of the mechanistic issues around hypoxia and hyperoxia, and increasingly now we're involved in clinical studies of addressing those kind of questions in both critical care and the perioperative setting.
In both those settings. Now, when this particular question came up when we were at the ASA in 2017, which is shortly after the WHO strongly recommended the use of a high fraction of inspired oxygen, about 80%, in adult patients undergoing general anaesthesia with the aim of reducing surgical site infection. Recorded on Top Med Talk, when we quickly went round the table of experts, we got a no, 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 no. So just as it stands, before I get into the papers, your personal interpretation of the available literature and then what you think is happening in clinical practice around you at the moment. So just to say, remind, WHO's strong recommendation, FiO2 of 80% during major surgery to reduce surgical site infection.
I think the accepting that there are a whole host of processes that the WHO go through to come to these recommendations, I think they overinterpreted the literature, so always and never statements are always a bit dangerous. But I have never met anybody who expresses agreement with that recommendation. The people either say, well, they're not quite sure, but most of the people who are informed are concerned about the recommendation, and I think that's reflected in a flurry of articles, particularly editorials in a number of journals, immediately after those recommendations expressing concern. And I think clinically, in the perioperative setting, I don't think it's an issue that is really focused on a lot. And certainly when we've done some background work for trials, so working with Dan Martin in London and two of the trainee networks in the United Kingdom, the evidence suggests there's a very broad spectrum of approaches to selection of FiO2, with the average sitting around 50%, but you get from 30 right up to 80, and there's no obvious pattern relating to seniority or location or anything else.
So your reflection on what people discuss, the literature and clinical practice you're aware of, suggests that it's undecided. It's a bit grey.
I think it is, and I think a number of themes that we may come across today will relate back to fluid therapy. I think it's like fluid therapy; it's pretty chaotic.
Okay, Tim.
I agree with most of what Mike said. I don't know anyone that uses 80% oxygen. I think there's a variety of oxygen percentages that are used, but somewhere in the 30 to 50% range, and it depends a little bit on the the machine that people are using, how they go about dialing up their oxygen, all these other factors come into, I think, the amount of oxygen that's given. But I don't know anyone that agrees with the approach of using 80%, which is very interesting considering we have these guidelines which were produced from largely outside the anaesthesia community. Don't know exactly the drive for producing these guidelines, but obviously the World Health Organization as a rule will produce high quality guidelines, and I think most of the anaesthesia community disagree with the strong recommendation, as Mike said.
And I think those of us in leadership positions have been maybe just slightly nervously avoiding complying with the guidelines because we don't necessarily believe they're right and we think it could be expensive and may even possibly hurt people. That's been so at work, if I've been on the SICU, I haven't been saying, my goodness, I don't believe the oxygen, the FiO2s are so low. I've been sort of keeping quiet because
my impression of the clinical setting is that most anaesthetists are less concerned about this than intensivists. So there are some who are focused on it, but the majority are not. And most intensivists, when you ask them, will state that they probably would tend to a lower, not a higher FiO2, including intensivists working on surgical high care units. But actually, exactly the same as the perioperative setting. If you actually look at what people do, the intensivists are also giving a broad spectrum of FiO2s and typically aiming for saturations that are relatively high.
Which might be a bit like the fluid discussions. It might mean that overall we don't think it's really that important, but sometimes if we look at very big data sets, it looks as though there is an important signal in there. It's just hard to detect every day of the week. So let's get into the two papers. Let's start first with the one by Steen de Jong et al. As I said, you can find the link to the paper. Well, actually, sort of the summary of the paper. I don't think it's open source at the moment because it's just around the time of going from in-press into publication, but you can certainly get in there into the BJA website. It's entitled The Effectiveness of 80% versus 30 to 35% Fraction of Inspired Oxygen in Patients Undergoing Surgery, an updated systematic review and meta-analysis. Now, they highlight the fact that the stimulus for this was this WHO strong recommendation that we've been alluding to. They've done a systematic literature search looking at literature from January 1990 to April 2018, all pretty high quality standard practice. They've ended up filtering down to 17 papers at the end of the day. And from the point of view of the effectiveness, the headline conclusion is that the updated analysis did not show definitive beneficial effect of the high FiO2. Mike, am I reading that correctly? Bottom line on effectiveness is overall no impact.
I think you are reading that correctly. There's some, in the small print, there's some discussion about whether particular groups, like for example, those who have been endotracheally intubated as opposed to those who are not, more typically having regional anaesthesia, there might be a bit of a difference in benefit. But I think the overall conclusion is it's not clear it produces benefit. And I mean, interestingly, the longer we go through this literature, the less evidence of benefit there seems to be. Partly due to the addition of new studies, partly due to the removal, as we may come on to, of some retracted and some uncertain studies.
Okay, so people jump to figure one if they've managed to get into the paper there. There's a flow chart of study selection. This is fairly standard in these large systematic reviews. At the top of it, they start off with the identification of papers, which is based on a database search. And they've found over 3,000, if I'm reading that correctly, Mike?
Yeah.
And then that, with the usual steps that goes through the screening and filtering, at the bottom of that, they get down to studies included in the meta-analysis, and that's down to 17. But as you say, there's on the right-hand side, there's 4 of them filtered out, and if I'm reading it correctly, it says formally retracted 1, under investigation at time of review 3. Did you find some detail on that in the paper, Mike?
So one of the papers has been retracted based on a reanalysis of the primary data by statisticians who did not come up with the same conclusions as the authors. So the authors had claimed statistical significance and the independent statisticians were unable to confirm that. So that paper has been retracted. And then a number of papers involving the same authors, so 3 other papers involving the same authors, are therefore under review as to whether they may or may not be retracted in future. So I guess we need to withhold judgment on those.
So when we get to the key results, that's there in Table 2 and Table 3. So the Table 2 is presented in number format, and it gives us a statistical analysis. Figure 3 is the classical forest plot by delivery of the intervention. Now, it's not explicitly written on the figure here, if I'm reading it correctly, but it's clear in the text that Figure 3 relates to the impact of this high FiO2, 80%, or the 30 to 35%, where the outcome variable being looked at here is surgical site infection.
That's right, yeah.
And overall, there's no statistical difference, but if you are going to get into which side of the line the summary statistic goes, it goes slightly towards the high FiO2.
It does, and then there's this subgroup analysis we've already alluded to, whereby if its oxygen has been administered via tracheal intubation, it just reaches statistical significance, so an upper confidence limit of 0.99. Whereas if it was oxygen was not administered by tracheal intubation, i.e. by face mask because of a regional anaesthesia technique, it does not reach statistical significance at all. And in fact, although it's not a significant result, the point estimate lies on this opposite side of the line.
It is very interesting, as you pointed out, Mike, and it's often the case when you start a body of literature, the first study is by far the most significant in favour of giving high oxygen, performed back in 2000, and then two further studies also reached statistical significance by 2007, but if you look at the last 6 studies, there was no difference, and none of them reached statistical significance. So there definitely seems to be a trend there as people have tried to replicate the results of that first study, and none of the recent studies have shown statistical significance.
And it's quite often happen when you look at these plots, I always sort of look at them and cover up one side then cover up the other side. And most of the studies are either sitting on the line of unity or possibly drifting out in favour, but there are ones going in opposite directions, which then draws us in to look at the biggest studies, and which is the biggest, Mike, that's distinctly looked at this question? I know there are larger data sets in there.
So I think the proxy study, which is the Meyerhoff reference, which basically sits on the line, which showed no difference in relation to in outcome relation to surgical site infection, is the biggest. That was specifically focused on the question of surgical site infection.
Because there is another big trial, a bigger trial in there, but that was answering a different question, so it's using that as a surrogate way of getting at the data.
Yeah. And I would say there are a couple of big, actually modestly sized studies in there, but of the studies we're looking at, the majority are single centre, and with a sample size, many of them down in the 1, 2, 300s, and this really, to me, is reminiscent of the goal-directed fluid therapy literature maybe 15 years ago, when we first started doing systematic reviews of that literature. And these are, in most other areas of clinical medicine, this would be considered a very new area with no definitive studies. And I mean, these are small studies that are not going to show statistical significance, and furthermore, being single centre, are significantly at risk of having bias.
Because this is the sort of question where you'd expect to be getting up to the tens of thousands of patients, isn't it?
That is what they are doing in the cancer and cardiology literature, and it's what we probably should be doing.
So the author's final conclusions is that they believe the WHO Guideline Development Group will reconvene to discuss the implications of these findings. So that's interesting. And they feel strongly that additional data from high-quality trials are urgently needed. Now the motivation for the urgent trials being needed, because this is going to take a lot of money, time and effort, is I assume that they're suggesting that the high FiO2 may reduce surgical site infection and therefore may be worth the time, the effort, the energy and the money.
I think that's their assumption, although that's an intriguing notion, because there's an awful lot of other clinical outcomes that might be impacted by this, that we have seen impacted, certainly in some of the post-hoc analyses of other studies.
Which brings us to the second paper, if we may. Are you happy, Tim, if we segue to the second paper to wrap this up? The second one appears to be the same data set, and there's some overlap in the authors here. It's a published alongside, so we're interpreting this sort of co-publication. It's the safety of 80% versus 30 to 35% fraction of inspired oxygen in patients undergoing surgery, a systematic review and meta-analysis. So we've just dealt with the effectiveness with regards to surgical site infection. This is the big niggling question. The people who don't like the high FiO2 are worried about the fact that there seems to be some association with worsened, very major outcomes, strokes, heart attacks, possibly even death in cancer surgery. There's a signal there. Although you may end up with less surgical site infection, you might end up with more people dead. So this is, I think, the motivator, quite appropriately, by my interpretation of this particular paper. And what do you think they conclude, Mike?
They appear to conclude that there isn't a significant safety signal. So, in fact, to quote, no definite signal of harm with 80% FiO2 in adult surgical patients undergoing general anaesthesia was demonstrated. And there is little evidence on safety-related issues to discourage its use in this population. And the bit I think that I would... the most important words in that conclusion are the little evidence.
Yeah.
And the reason I say that is... hopefully I'm reasonably good at counting. When I went through the table around what they call the matrix of adverse events, so where they map a sequence of different potential adverse events against individual studies, of the 125 possible cells in which there could have been an outcome, 100 of them have NR in them, which is not reported. So for the vast majority of outcomes for most studies, we simply don't know the answer. Where we do know the answer, it's not too scary. But again, it's a slightly different group of studies, but it's essentially the same core group of studies. There are lots of outcomes that haven't been reported, and there's still relatively few, relatively small, predominantly single-centre studies. So this, to me, is not reassuring. It's an absence of evidence as opposed to an evidence or absence of harm.
And it's not a criticism of the paper or the way the paper is conducted. This is extremely well done. All the evidence is available there, but the conclusion needs to be interpreted as there's not much to make this judgment call on.
Yeah, it looks like an excellent systematic review by certainly some of the authors are highly experienced in this area. I would have confidence in the work, but I'm just not quite sure I agree with the conclusion based on the evidence presented.
Because you're drawing us, it ends up in the figure of filtering down the studies. It looks like we get filtered down to about 11 that are majorly in play. Right. If you go to the table number 4, this is the one that even if you stand back and look at it, it is dominated by NRs. So if you look at it from arm's length, you see a lot of NR. That means for atelectasis, pneumonia, cardiovascular events, ICU admissions, length of stay, mortality, it's dominated by not reported.
Yeah.
So no criticism of the people who've done this work, but important to note that we don't have data on most of those things. So surgical site infection may have improved in some situations, but we don't know if it caused additional harm as it stands. And that, I think, is also then reflected if you look to figure 2, which is the pooled risk ratio for adverse events. Some of the tables have got 3 studies in them. Yeah, which with very, very few patients involved in total. So, well done to the authors for all the hard work. Well done to BJA for publishing this. It looks like the conclusions are that this is still a known unknown, and we might be seeing, we may not, the guidelines changing. Do you think, Tim, it will have any impact on clinical practice where you work at the moment?
Well, it's interesting. Just as I say, I don't think clinical practice has changed dramatically with the work that has been carried out over the last 5 years, including the WHO guidelines. That may be multifactorial, but I think the administration of oxygen for major surgery is fairly similar now to practice 5-10 years ago.
Mike?
I think what these 2 systematic reviews say to me are it's still a very young literature. I do not believe that the WHO recommendations are sufficiently supported or substantiated by this evidence base. I think I remain nervous, and particularly I remain nervous, I guess, reflecting back on the beta blocker story and the incentives aligned to prescribing beta blockers, and then at the end of it all we have poise and we discover that actually beta blockers can kill people. And I think we need to be very nervous about, so WHO guideline, the potential for incentives to be being put alongside that to, on the face of it, promote good behaviour, when there may be, we have no idea whether there would be unintended harmful consequences from that or not.
Tim, Mike, thank you very much indeed for everything you do to contribute to Top Med Talk. Everyone who's listening, if we haven't said it already, Happy New Year.
Happy New Year, Monty.
Happy New Year.
Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.